Hello doctors. Today our topic of discussion is Glasgow Coma scale and brain injuries. So GCS is Glasgow Coma scale. GCS have three components. Number one is the eye opening, number second is the verbal response, and number third is the motor response. In the eye opening, there are highest score is 4. In verbal response, the highest score is 5, and the motor response, the highest score is 6. When the patient comes to you and his eyes are already opened and responding eye response is present, then it is known as spontaneous and score is given 4. When he is responding to the sound, when you tell the patient's name, hey Raju, wake up, and when then that time he opens the eyes, then it means he is only responding to the sound, and again after responding for some time he closes his eyes, then we will give the score 3. And when we give pressure, means when we give pain, when we pinch the patient, then and at that time he opens the eyes, then we give the score 2. And when the patient not at all open his eyes, then we give the score 1. What are the verbal responses? Verbal responses means he is oriented to, the patient is oriented to time, place and person. He can tell where he is, he can identify the person near him, and he can tell the time, whether it is morning, evening or afternoon. Then we give the score 5. When the patient is confused, then we give the score 4. When the patient are only telling inappropriate words, then we give the patient score of 3. And when there is incomprehensible sounds or inappropriate sounds, then we give the score 2. And then when there is no response from the verbal response from the patient, we give the score 1. There is motor response. In motor response, when the patient obeys the command, when I tell the patient lift your hand or lift your leg, and he lifts up, then we give the score 6. When the patient localizes the pain, when I give the pain to the hand and he localizes where I am giving the pain, then we give the score 5. And when there is normal flexion, means when you give the pain to the patient, then he withdraws his hand, then that is the normal flexion. And then we have the abnormal flexion and abnormal extension. Here we can see this is abnormal flexion, and this is the abnormal extension. Abnormal flexion is known as decorticate posture, and abnormal extension is known as decerebrate posture. Now we will see the brain injuries. So brain injury, according to GCS, we can classify as minor, mild, moderate and severe. Here in the GCS, if we add the total, the maximum score is 15 and minimum score is 3. So in minor brain, when we call it minor, we will tell when the GCS of the patient is 15 by 15 without history of loss of consciousness. We tell it mild when the score is 14 to 15 with loss of consciousness. And moderate is when the GCS is 9 to 13, in between 9 to 13, and severe is when the GCS is less than equal to 8 and we need to intubate the patient. Now we will see the isolated brain injury. One, you must know, in isolated brain injury there is no hypovolemia. In brain injury, hypovolemia doesn't happen if there is only brain injury. But if there is hypovolemia present, if the patient comes to you with a brain injury and hypovolemia is also present, then we have to suspect there might be blood on floor or blood in thorax, abdomen or in pelvis, or there is long bone fracture. Okay, this is the hypovolemic shock we will see in the later on videos. If there is a patient of head injury with low BP, then we must check for spinal cord injury along with head injury. Because of spinal cord injury, there may be patient might have low BP. Now we will see the brain injuries. The brain injury can be primary or secondary. The primary is mainly due to impact, okay, and the secondary brain injury is due to increase in intracranial pressure, which leads to intracranial tension, which causes secondary brain injury. Before going into the secondary brain injury, we have to know the Monro-Kelly doctrine. Here we can see what is the Monro-Kelly doctrine. Monro-Kelly doctrine means skull is a closed cavity. Okay, the skull is the closed cavity. This is a closed cavity. If there is a mass present, suppose, or any kind of bleeding present, hematoma, contusion present, then because of the mass, there will be blood will be drained out or the CSF will be drained out. If the mass is small, then the ICP will still be normal, and this state is known as compensated state. Okay, when the mass is large or increasing in size, the ICP gets elevated, and this is known as decompensated state, and which causes increase in intracranial pressure. So this is important. You have to know this is Monro-Kelly doctrine. Now we have to know the formula. The increase in cerebral perfusion pressure is equal to mean arterial pressure minus ICP. We have to also know that you should not confuse in between the Cushing reflex, curling ulcer, and the Cushing ulcer and the curling ulcer. What is Cushing reflex? Cushing reflex is bradycardia, hypertension, and altered sensorium. And curling ulcer is stress ulcer in the stomach due to head injury is Cushing ulcer, and curling ulcer is burn due to burn. There is stress ulcer in the stomach. So curling ulcer is due to burn, Cushing ulcer is due to head injury in ulcer, and Cushing reflex is different. Now we have to see the management of increased in intracranial tension. What will you do if patient have an increased intracranial tension? Number 1, we will give adequate oxygen, first of all. Number 2, we will have to give adequate perfusion. Okay, the perfusion, the SBP, we have to maintain approximately more than 100 mm of Hg. Number 3, we have to avoid hyperglycemia. We have to avoid the hyperglycemia. Number 4, we can use IV mannitol. What does mannitol do? We will use IV mannitol because IV mannitol is hyperosmolar. And this hyperosmolar state will decrease cerebral edema. Therefore, mannitol is good while in patients of head injury. Number 5, hyperventilation. Only in moderate amount, not much. It has been seen that steroids have no role. Steroids have no role. Steroids are not given in cases of management of traumatic brain injury. Most of the time it is asked in MCQ also. Steroids are not given. Best for vasogenic cerebral edema in tumors. Steroids are given in cases of mass in brain or tumor in brain, but there is no role in traumatic brain injury. Okay. Now we will see diffuse axonal injury. So what is diffuse axonal injury? Diffuse axonal injury is most severe and it has worst prognosis. What is the mechanism? What is the mechanism? Why does the diffuse axonal injury occurs? It occurs because of shearing force. Shearing force in between gray and white matter. In between gray and white matter, there is a shearing force which causes diffuse axonal injury. And what are the clinical features of the patient? In diffuse axonal injury, the clinical patient will be in coma, and the Glasgow Coma scale, that is GCS, is not improving. And the main part is, instead of this having very severe, still the NCCT head is normal. So the diagnosis is done in MRI. And what we will see in MRI? What we will see here? In MRI, we will see punctate hemorrhage at gray and white matter junction. And this punctate hemorrhage in gray and white matter junction is most commonly seen in corpus callosum. And if we see, if a patient dies after diffuse axonal injury and we send the specimen of brain, in histopathology we will see clubbed region, clubbed axons and retraction balls. Okay, so this is seen in diffuse axonal injury, most severe type, worst prognosis is there, and shearing force is present in between the gray matter and the white matter, and we diagnose via the MRI. So now we will see the intracranial hemorrhages. The intracranial hemorrhages are contusion, EDH, extradural hemorrhage, SDH, subdural hemorrhage, and SAH, that is subarachnoid hemorrhage. Subarachnoid hemorrhage is the most common cause of subarachnoid hemorrhage is trauma. And this contusion is the most common type of intracranial hemorrhage that occurs in trauma, is the contusion. Most common type of intraparenchymal hemorrhage. Okay, now contusion most commonly occurs in temporal region. Here in the image also you can see this is the contusion which is present in the temporal region. Most common is the temporal region. After that, second most common is the frontal region. Here the contusion are present. Now the contusion may get resolved by itself. It can get resolved, no need to do anything. And if doesn't resolve, if the contusion does not resolve by itself, first we will have to try to do conservative management. If the conservative management, the patient resolves, contusion resolves, then it is fine. If the size of contusion increases, then we have to do the treatment is surgical management. So this is about the contusion. Now we have the extradural hemorrhage. This is extradural hemorrhage, or we can say extradural hematoma. So what is the mechanism when this happens? The mechanism is when there is high velocity impact. At that time, the extradural hemorrhage occurs. Generally, it occurs in young patients, and here the bleeding, as you can see here, this is lens shaped, bilateral, biconvex lens shaped, and this bleeding is mainly from the arterial bleed. This is arterial bleed. This is arterial bleed, and most commonly which artery bleeds here, this is the middle meningeal artery. The clinical features: patient will have drowsiness, dizziness, but the most important which we have to remember, that patient will have lucid interval. This is very common in EDH, but it can be seen in other brain injuries also. Investigation of choice: as you know, investigation of choice is NCCT head. Okay. Now, in the patient of EDH, when to do craniotomy? This is an MCQ question and generally asked in exam also. When to do craniotomy? When we will operate the patient. So craniotomy is done, number 1, when there is more than 30 cc clot size. When the size of clot is more than 30 cc. Number 2, when there is more than 5 millimeter midline shift. This is the midline, and if it is deviated more than 5 millimeter, then we have to operate the patient. And when it is more than 1.5 centimeter thickness, the hematoma have more than 1.5 centimeter thickness, any one of these is present, then we have to do the craniotomy in patients of EDH. If there is an emergency and you don't have anything at that time, the patient is not in the hospital and you are in the emergency site, then emergency management, we can do burr hole. Fine. In EDH, we have to know one more important thing. We have seen the lucid interval. Lucid interval means in between 2 episodes of coma or drowsiness, the patient will be absolutely normal and we will think that patient doesn't have head injury. But we have to think about the lucid interval, especially in patients with EDH. Here we have to know another very important thing, that is false localizing sign. False localizing sign. So what is false localizing sign? The false localizing sign is, example, suppose patient have left-sided EDH. So there will be left-sided dilated pupil. As we know that if we have injury over the left side, generally the right side gets paralyzed, and when the right side gets paralyzed, we think that the injury must be in the left side. But here the false localization occurs, because suppose when there is large amount of EDH, large amount of blood is gone, then there is, in the temporal region, we have the uncal herniation. We have uncal herniation. on left side. So it causes, as there is herniation, it causes pressure on opposite side. It causes pressure on right corticospinal tract, and there will be left-sided hemiparesis. And when we will see in patient clinically there is left-sided hemiparesis, we will think that the injury is on the right side. Therefore, this is known as false localizing sign, and this is also known as Carnohan notch. Okay, Carnohan notch phenomenon. Okay, this is also known as Carnohan notch phenomena. This is the false localizing sign. EDH we have, it causes temporal left-sided uncal herniation which presses over the right side, and in the right side the corticospinal tract gets injured, and which causes left-sided hemiparesis. So this happens in patients of EDH. So we have seen the EDH, biconvex shaped lucid interval, everything, and when to do craniotomy. Now this is the SDH. So what is SDH? This is subdural hemorrhage, and SDH is also known as pachymeningitis hemorrhagica. Pachymeningitis hemorrhagica intera. Okay, in MCQ sometimes instead of SDH they can write this. Now SDH can be of acute or subacute, or SDH can be chronic. When we will see it is acute means when it is SDH is for less than 3 days. Subacute means when the SDH is for 3 to 21 days. And chronic means it is more than 21 days already. And this chronic SDH automatically generally happens in elderly patient due to trival trauma. And in cases of EDH, we have seen the bleeding is from the middle meningeal artery. But in SDH, the bleeding is from vein. The bleeding is from vein. That is venous bleed. And from which veins? The veins which are, that is cortical bridging vein. From the cortical bridging veins, the bleeding happens. And here, the bleeding is, as we can see here in the image, this is an image of SDH. This is crescent shaped. That was biconvex lens shaped. This is crescent shaped. And bleed is between dura mater and arachnoid. Here also there is indication. So in SDH, we will see when to do craniotomy. Number 1, when it is more than 1 centimeter thickness is present. Number 2, more than 5 millimeter midline shift. This indication was also present in cases of EDH. Apart from that, if GCS falls more than 2 points, then also, and if intracranial pressure is more than 20 mm of Hg, and if the patient have fixed dilated pupil. In last 3 criteria, any 2 of these three. Any two of these three is present, then we will do, or if any one of this is also present, then also we have to do the surgery, that is craniotomy. And the extent of brain injury, SDH injures the brain more than EDH. Okay. And there is also subarachnoid hemorrhage. Subarachnoid hemorrhage, most common cause of subarachnoid hemorrhage is trauma, and it is majoritarily managed conservatively. Now we have the Glasgow outcome score. Glasgow's coma score that we have already read, GCS is different and Glasgow outcome score is different. Glasgow outcome score, you have to just remember that the 1 means death, second means neurovegetative state, third means severe disability, fourth means moderate disability, and 5 means normal patient with good recovery. Fine. Now we will see the last part of this topic, that is the brain death. When we will tell the patient is dead. Number 1, when the GCS is equal to 3. Number 2, when there is non-reactive pupil. Pupils are not reacting. Number 3, absent brainstem reflex. Absent brain stem reflex. Okay. Number 4, when there is no spontaneous ventilatory effort. On apnea test. On apnea testing. And number 5, there is absence of compounding factors such as alcohol. There is absence of compounding factor like alcohol or drug intoxication or hypothermia. And what are the studies in which you will confirm that the patient is brain dead? Number 1 is electroencephalography. Then we can do the CBF studies, and we can do cerebral angiography. So these are the tests and these are the symptoms or clinical signs that are present in a patient of brain dead. We should also remember that sometimes the patient, when the patient is in barbiturate coma or patient is having hypothermia, these two condition mimics brain death. So we have to carefully check everything in this patient if the patient have hypothermia and barbiturate coma. Thank you for watching, guys. We will continue with the trauma of general trauma in our next video, and please do like, share and subscribe to support me so that I can make more interesting videos for you guys. Thank you.